let us talk about supraglottic airway device. And as I told you, supraglottic airway device remains above the glottic opening. It does not cross the glottic opening. That's why it is called supraglottic airway device. So let us see an image of supraglottic airway device. So this is a supraglottic airway device, classical laryngeal mask airway. This is prototype of supraglottic airway device. So supraglottic airway device, they remain above glottic opening, and the first device which I would discuss in this would be classical laryngeal mask airway. Classical laryngeal mask airway. Now this device was designed by Dr. Archie Brain. Dr. Archie Brain. Okay, so that's why it was also called initially Brain's LMA, right? It's popularly called LMA, the classical LMA. This was also called Brain's LMA. Okay. Now let us talk about Brain's LMA or classical LMA. See, this is the cuff. So this is cuff. This cuff has this pilate balloon system to inflate it. So it can be inflated by this pilate balloon system. So we can put air and this cuff will get inflated. Now this back portion is the dorsal part of the classical LMA, and it does not have any opening in it. On its ventral side there is a opening. This is opening, and this has two, let's say, ridges to lift the epiglottis from falling on it, to prevent the epiglottis from falling on it. Okay, so opening with vertical ridges, vertical ridge. Okay, and if you see this opening, this is connected with this tube. Okay, so I can insert my pen also through it, and this is the tube to which it is connected. So this is airway tube, and this airway tube has this universal connector, like the universal connector of your endotracheal tube. So universal connector. Okay, so how do we insert it? Like any other airway device, it is held in the dominant hand. So if you see the image 1, how do we hold it? We hold it in pen holding fashion. So I am holding it in a pen holding fashion, and then I open the mouth of the patient, and with pressure applied through my finger, I just make it flat on the posterior pharyngeal wall, and I make it flat and start applying pressure down, 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 down. So I start applying pressure with my index finger. I insert it. It follows the path of the least resistance, as you can see in the 2. And when I push it, and now I cannot push it any further. I am facing a maximum resistance. I take my hand out, I hold it, and then I inflate the cuff. It comes little out for a right positioning. Now what happens? This opening is against the glottic opening, and this tip goes into hypopharynx. So you see, this is the tip which is blind. This tip is blind, doesn't have any opening, is in hypopharynx, right? And the opening is against your glottic opening. This is against glottic opening. So this is the proximal opening, this is the distal opening, and through which we can ventilate the patient. So this is against glottic opening. Okay, so this is our classical LMA and the method of inserting it. So as you can see, we do not require any laryngoscope to insert it. We just open the mouth, push, 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 push. So if you have gone through how do we insert the endotracheal tube with the help of laryngoscope, for inserting endotracheal tube, we need to have little knowledge of the anatomy of the airway, how to hold the laryngoscope, what all we have to see, etc. But here, we don't have to do anything. We just have to open the mouth and push, 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 push. It goes and sits at the right place. Studies have shown that even a naive inserting it would go and sit at the right place in 99% of the time. So it is very, very, very easy to insert and very quick to insert. So let us write some of the benefits benefits of classical LMA. Okay. First, it is easy to insert, as just now I demonstrated. Easy to insert, fast to insert. ET tube insertion would take more time than LMA insertion. Fast to insert, then does not require laryngoscope, so no laryngoscopy response, no sympathetic stimulus. So it is a less invasive air device. This cuff is a very soft, made up of very soft silicone material, easily tolerated. So less invasive, so less complication. Okay, all these are the benefits, but the major issue. So when you put the tube, we all know tube has a cuff. So when I am putting endotracheal tube, the tube cuff, when it inflated, it creates a very good seal in the trachea, 99.9%, no risk of aspiration. But when you are putting this, it is also creating a seal over the glottic opening, but the seal is not strong enough to prevent aspiration. The major drawback, aspiration cannot be prevented. So the major drawback of classical LMA, major drawback of classical LMA is that aspiration cannot be prevented. Aspiration cannot be prevented. So if aspiration cannot be prevented, we cannot use it as a definitive airway. So how do we define a definitive airway? Let me define a definitive airway for you, right? So definition of definitive airway is that the device which can be used for ventilation and can also be used to prevent aspiration. So it has to do both the job. So a device, an airway device which can ventilate and prevent aspiration, which can ventilate and prevent aspiration, right? So any device which can ventilate and prevent aspiration is definitive airway device, okay? And LMA can ventilate but cannot prevent aspiration, classical LMA. So it is not a definitive airway device. So the major demerit, the other demerit, cannot be used for a long time period, not a definitive airway device, okay? So this is the demerit. So Dr. Archie Brain, who designed this device, noticed this demerit.